I love cars, and I've had everything from Model Ts to Porsches and things. I just love cars and the evolution of cars. And you speak to it. Medicine is not a Jiffy Lube. I'm not against Jiffy Lube. It's a great, company.
Right.
These fast oil changes. That was an evolution. Medicine can't be Jiffy Med or something. That's what doesn't work. It can't be faster and faster. And insurance might want that. Some healthcare organizations might want that because you bring in revenue for every encounter. Evolving out of the encounter-based, just how many clicks, how many people you can get in front of you, to quality and meaning-based, building relationships, educating patients, helping them stay well instead of just, what's the problem? Here's your quick fix. Did it fast, 10-minute visit, go on. If we can build ways that help achieve those goals of efficient care, but also meaningful care that patients feel like they were heard and they buy into the care and buy into that journey, that's what's going to keep them well long-term.
Welcome back to MasterMined. I'm your host, Mark Scrivner, and as always, I'm joined by my much wiser co-host, Jeff Skillen. Jeff, welcome to the show, man.
Mark, thank you. It's always a pleasure. Glad to be here.
How excited are you for this episode?
Very much so. I mean, it's like when we met Dr. Milam earlier to talk about this, what I thought was going to be a great interview turned out to be an even greater opportunity. So, yeah, I'm looking forward to this.
Yeah, this is going to be a good show. In this episode, we're joined by Dr. Tom Milam, Chief Medical Officer of Iris Telehealth and President of Iris Medical Group. Tom, welcome to the show, man. It's great to have you on today.
Great to be with you all. It's a real pleasure to be here.
Yeah. Well, hey, before we get into Iris Telehealth, and I know we're going to talk a lot about that, but maybe you could just take our audience through your journey. You've had a great journey to get you where you're at today, and would love to just set it up for the audience.
Sure. Happy to walk through that. I've been a psychiatrist for about 30 years and practiced in Wilmington, North Carolina for many years. I had a private practice there doing ambulatory work and inpatient psychiatry consultation. Really enjoyed the work and learned a lot about working with rural communities, about half children, half adults, a lot of Medicaid population. But increasingly learned about the health system, things like billing and coding, access to care, and got really concerned about that and about how many people that needed health care, particularly behavioral health care the most, had trouble accessing it. And so my wife and 4 kids and I moved to New Zealand. I actually spent over a year there studying how they did healthcare delivery, practicing there as a psychiatrist with people from all over the world. It was a great experience. Living in New Zealand, beautiful country. It was fantastic. And learned a lot. And when I came back, I was invited to join the faculty at Virginia Tech in Roanoke. They built a new medical school and research institute. So I was part of the beginning of that, which was a lot of fun. So I came on faculty and eventually was interim chair of the Department of Psychiatry in 2016, 2017. I increasingly got interested in telehealth. It's sort of rooted in many years ago when we moved from North Carolina, ended up back in Virginia. I was running a pediatric residential treatment center, and I couldn't find anybody to take over for me. So I was commuting on weekends, like 6 hours each way to see these 15 children. And then I thought, well, why don't we try once a month doing it through telehealth? Worked really well, so we started doing it more. We were able to connect families so they didn't have to drive long distances to see their children. We were able to connect with staff and other people involved in the lives and care of these children. And so that helped me see early on, this was back in 2010, saw early on how delivering telehealth is a real win for a lot of families, particularly in rural areas. And that's what I experienced at Virginia Tech. People driving 2 or 3 hours up the valley in Appalachia, that region, just to get health care. And I thought we could do better than this. How can we go to them? How can we support them in their communities? And that's where I got into telehealth and doing that. Eventually was invited to join Iris Telehealth and did that been there about 8 years. And it's been really wonderful.
Well, so you were into telehealth before it was cool, basically, right?
Yes, I was cool, even if telehealth.
Well, it's, yeah. I mean, it's really fascinating because, I mean, a lot of the people who are listening to this podcast is like, of course, they were vaguely aware of the opportunity for that, But then COVID happened. And then, of course, everybody thought, oh my gosh, this is going to be the turning point for telehealth. And you were already doing it. So, I mean, how did that impact you? And then, what was your vantage point there?
No, I'll tell you, it was an interesting question because I joined Iris in 2018. So if you can imagine, 2018, like a little bit before COVID, we were extremely busy, with a real mission to support communities. So we did a lot of community mental health care, FQHCs, rural health clinics, as well as working with hospitals, working in the emergency rooms, things like that, meeting unmet needs around the country. And that's how the organization grew, leveraging telehealth to do that, to put providers in front of patients so that they had access. When COVID hit, we were in a position to work with organizations to show them how you could transform into offering services through telehealth. And that was for physical health as well as behavioral health because it's the same platforms. Some people need to be seen physically and had physical examinations, things like that. And in-person care is still kind of the gold standard, something that we all enjoy doing. But for those who don't have care or don't have access to it, or for whom traveling and the cost of going to a healthcare appointment is just exorbitant, doing telehealth and delivering to them was a real win. So working with more and more systems on how to do it effectively and how to do it cost consciously. Because back in 2010, when I first began to look at telehealth and going to conferences, the cameras were expensive, the switches, the codec stuff was so expensive, the security issues and data protection, everything was just so expensive. And finally, I remember in, it was like 2015, working with a group and just said, you just need an iPad, put an OtterBox on it. A kid can throw it or punch it or whatever. If they get angry, it doesn't matter. It's indestructible. We can work with that. Connect to your internet in your office. Some simple solutions that helped organizations within a few weeks of COVID hitting, helping them transform to deliver healthcare so their patients didn't suffer. And it was really meaningful.
Tom, you are acutely aware of the lack of services when it comes to psychiatry. I mean, you've been doing this for over 30 years, and it seems like that access has really sort of driven your passion towards building this out. Could you and I know you spoke about the Medicaid population, you spoke about the rural population. This entire country still remains underserved when it comes to psychiatry services and mental health services. So what is your approach to addressing that gap?
Well, I think, that's sort of the $1 million question. It's not one that's just for behavioral health. Access to primary care for keeping people well with diabetes, with COPD, asthma, hypertension, early detection of disease. It's the same processes in behavioral health. How do people take care of themselves in the early days before things become a problem? There are never going to be enough behavioral health providers. Just look at primary care providers. Family doc, pediatricians, interns, they are on the front lines. They are seeing the bulk of people with behavioral health problems as well as physical health problems. Love working with primary care providers who are doing integrated care and those kind of models. I think it gives us the opportunity to look at something and say, this is short supply. Reimbursement rates never really cover the costs of psychiatrists or a lot of psychiatry services when you're looking at traditional billing and coding. So it calls for a different approach to how we address mental health and substance use disorder needs. And I will tell you, in my lifetime, I've never been more hopeful about the opportunity for people with mental health and substance use disorders to get care than I am now. It doesn't mean it's perfect now, but the awareness about the disorders, the stigma has really become more broken and broken down. We see younger people more willing to talk about anxiety, depression, stress, early detection of suicidal thoughts and things like that in young people, and really changing the culture around behavioral health as being something that you just didn't talk about. So working with families to talk about it, learning a lot of it, like with physical health illness, a lot of behavioral health is genetic. So when someone comes to me and they have alcohol problems or substance use or some other type of severe mental health problems, I don't say, does anybody else in your family have this? It's usually, how many people in your family struggle with this? Tell me about that. Because when you can feel like, particularly with mental health, when you're helping people see that it's not something they did wrong, it's just part of their genetics, part of their makeup, and how they've grown, how their life has evolved, has led to circumstances where they're experiencing depression or anxiety or alcohol use or substance use. They didn't do anything wrong, but it's affecting them. And to be part of that journey, to be invited in, is a wonderful experience. So it's a great time to work with patients to leverage that communication between providers and patients. Telehealth creates opportunities to do that like we've never had before.
Well, so let's get practical in terms of how Iris sort of fills that gap, because I mean, what I'm picking up on, and just make sure that I've got this right. So you really provide this, you fill in this gap like at emergency departments or primary care offices where a patient could use a consult. A patient could use access to a mental health professional, and is literally, they're going to bring in an iPad and they're going to say, here's someone that can speak to you today, or we can schedule someone. And so then, you don't have to be in that office in Blacksburg, Virginia. They actually, they either a computer terminal or an iPad brings that person to the patient. Is that accurate?
Yes, exactly. Yeah, I'll tell you how we started it with Carillion. I've mostly been an inpatient psychiatrist much of my adult life. But in my ambulatory clinic work, I also saw how, as I mentioned before, patients had to drive sometimes 2 or 3 or more hours to get to an appointment. You think of the time they had to take off from work, so an entire day of work missed. So that's less income. And even had children, young children that they brought with them, or they had to find childcare for. Some of them faced losing their jobs just by having to take a day off because they weren't allowed to. Did they have transportation, paying for gas, paying for food along the way? So there's all these barriers. So I worked with a family medicine group, a group about a half dozen docs, nurse practitioners, because I'd gotten a lot of referrals from them. And I said, let's try a new model. When you have a patient in your office that's come in, and maybe they're struggling with the behavioral health issues, substance use issue that you need some assistance with, how about you just call me? Just text me and say, hey, Tom, we've got someone here. And we got them an iPad. I would go down to my office. I mean, I could stop on, you're doing inpatient work. You can pause your rounding. I'd take my team, usually I have med students and residents, go down to my office, log in, talk to the provider, put the patient in front of the iPad, talk to the patient, talk to the provider again, and make recommendations, documenting all this stuff in the electronic medical record that we all shared. And it really worked out well. What was interesting, I'll tell you, Jeff, is we did it for a long time, but after about 6 months, I noticed that the rates at which they were calling me was less. And so I asked them, you know what, you're not using it as much. Is it not working? Not happy with it? Is it the culture around telehealth? And they said, no, Tom, with seeing you and your team again and again and again, explaining things about how to manage more significant mental health and substance issues effectively, we've learned how to do it more ourselves. We feel more comfortable. And that was really cool, because that's how you expand services, not by hiring more psychiatrists or nurse practitioners, because there's never going to be enough. It's about teaching people who are on the front lines and equipping them with the tools to do it effectively. Your family docs, your pediatricians especially, working alongside them to support them in the work that they do. Because I used to refer people to pediatricians, developmental pediatricians, and things like that. They used to refer to me. And in the old days, you just said a thank you. Thank you for this referral. Appreciate it. And then you never had any contact. And the friends who are pediatricians are like, they're just lost to a void. We don't ever know what happens to them. And that was another opportunity to create channels for communication about patients, to form the care teams around them. And that's what you see evolving today. Telehealth can pull together care teams, and they don't all have to be in the same building, in the same town, in the same state. You can get very creative in how you can pull together experts and others involved in different levels of the care of a patient. So I think that's where the future is going is how do you build care teams through telehealth, not just connect to one provider. That's great, but it's still one-to-one. Are there ways to change that ratio where you have one patient and you can have a number of care team members connected to them, some in person and some through telehealth, that can help them stay well?
Yeah, Tom, like hearing your background, I mean, you've done a lot. I mean, you've practiced internationally, you've had your own practice, you've served in academic leadership, even doing research on you. We see that you hold both a MD and a master's in divinity as well. And maybe if you could just talk a little bit about like how all of those experiences set you up to the way you lead Iris Telehealth today.
But yeah, I really appreciate that question, Mark. It's I come from a generation of doctors. My dad, one of his brothers, both my grandfathers were physicians. I have a daughter that's an emergency room doc at Penn. Another son just got accepted to med school. So it's kind of been in my blood. But my father once said that with managed care and all that, medicine is just not what it used to be. When I was growing up, my dad was a urologist, small town in Virginia. People might pay him with a bottle of homemade, hooch or whiskey, or pay him with a horse for our farm or something. You could do those kinds of things. It's not allowed anymore. But I grew up with that. But he also said that the climate is changing such that it really, the impact of managed care in the relationship between a provider and a patient became more negative. The regulations, the rules, the billing, and all that kind of stuff. And he tried to talk me out of it. At the same time, I always had this interest in evolutionary biology, cultural anthropology, spirituality. Growing up and just seeing how different cultures around the world and the States had different ways of experiencing the divine or the spiritual lives. And I just always thought that was really beautiful. My mom was a alcohol detox counselor, and when I was growing up, I used to go in and see her working with folks, different religious and spiritual traditions or no tradition at all. And so a lot of that kind of I grew up with, so that I studied science, biology and chemistry and those kinds of things. But I also loved social sciences, anthropology, sociology, evolutionary biology, and just the human spirituality. And so I did get my master's in divinity from Yale, seeing that spirituality is something is a wonderful thing, like music or art. It has real healing potential for many people. I'm not a great artist. I can still appreciate art. But it's leveraging that kind of strength in humans and in cultures to promote healing. So combining the science of healing with the various traditions around the world of spiritual healing and being able to speak to that. For many people, their religious backgrounds, their spiritual backgrounds is a very important part of their healing, important part of their family. And for those at whom it's meaningful, you can speak to that. You can support that as something that's just as important sometimes as the medications and the therapies I'm going to be delivering. So I took a lot of time to learn about that and different traditions around the world, and I tried to incorporate that, not with directly proselytizing or anything about my tradition, but by asking patients, do you have any spiritual or religious traditions that are important to you that you want to share with me, that are part of their healing journey? And you would be surprised. It really opens up some doors.
Mm-hmm.
And so combining sort of the cultural and spiritual aspects of people's lives with good medicine, to me, is what optimizes the healing process.
Yeah. Thank you for sharing that. It's great.
Yeah, I mean, that's a dimension that I think isn't discussed enough, frankly. And, it's reassuring to me to know that, there are physicians and psychiatrists out there that actually bring the art along with the science. And because, I mean, we speak with a lot of people who, and this is not to say that you aren't top notch on the science side, but it's like you bring a dimension that's not always present. And I think a lot of people who use the services kind of wish or hope that were present. So it's like, I'm not just in a control group. I'm not just a case number. I'm not just, patient 1, 2, 3, 4. Right. And they want to know that they are fully alive and that someone recognizes their humanity. And I think that's just beautiful that we're talking about.
Well, thank you. It can be a challenging topic that sometimes you try to avoid in families and in clinics, like talking politics or things like that. I always enjoy talking sports. You can see I'm a big sports fan, and I was a Commanders fan or Redskins back then, and someone would come in wearing a Dallas Cowboy T-shirt. We'd have a great time about it, and patients began to wear their other shirts from other clubs when they come to appointments, and you can have a lot of fun talking about certain things. Getting into spirituality, religion, politics could be more challenging, and yet, particularly for behavioral health and addiction kind of issues, where people are often questioning themselves, whether they belong in this world, their connectedness to others, the feelings that you see a lot more these days: isolation, despair, loneliness. These are big areas where spirituality and mental health services can come together and promote some real healing. And as I said before, some patients are really open to that. And so creating an environment where they can be themselves and share their beliefs, and you can affirm the healing power that those folks believe in, whether you share that tradition or not, or have any spiritual background yourself. That's kind of what I teach. It's not about you as a provider. It's about what are the strengths that patient brings to the journey that you can work with in part of the healing process. And when patients know that that is something they can talk about and that you support it, even if you don't understand their whole religion or their spiritual beliefs, it's a win. It does open doors that I find over time, and having doing this a long time, open doors to healing that to me makes me feel better about where that person is going in their journey, knowing that it's not just me along the way. It's their belief systems, their spiritual strengths that they bring, and trying to leverage those in the healing process. And in behavioral health particularly, we need everything we can get to get people feeling better and feeling more themselves.
Well, I just want to add one other comment, and then we're going to go back to about Iris. But just it's rare that we get the opportunity to speak about this topic. But I mean, this reminds me of a Christian theologian that I'm a fan of, Marcus Borg. He talks about meeting people in thin places, and he talks about the opportunity that people who are open to have this conversation. And then I also think about you with your psychiatric background. I mean, you're almost like the perfect nexus of meeting people in thin places. And so I just wonder how that resonates with you. And then what are your thoughts about that?
I like that. I love the work of Marcus Borg, just an incredible person. His books were great, very accessible books about spirituality and how they can be foundational for humans and their journeys. I love Paul Tillich.
Oh yeah.
He once said, it was something later quoted by Frederick Buechner, another theologian, that said, "Here and there in the world, and now again in ourselves, we experience a new creation." So to me, it's the hope, it's the opportunity, it's creating that for patients. Prescribing and doing all that, that's the easy part for me. And in some cases, it's more complex with severe chronic mental illness. But instilling hope, instilling a collection around, we're all on a journey of healing. None of us is perfect. We're here together to do this, and building that part of the trust in the relationship with the patient, with the family, is just key to the healing process. I am an Episcopal priest, so I have that as my background. And I feel that in behavioral health, particularly in addictions work as well, people are inviting you into the holy places of their lives. I often say when I'm teaching residents or med students, that being invited in people's suffering and a journey, is you're on holy ground, and it requires you to be very competent in what you do, to be skillful, to be attentive to what the patient is bringing, not just what you think you can do to heal them. I do worry at times that the pace of medicine, the administrative burdens, the EHR, there's so many things that just kind of keep us so busy that sometimes you can lose sight of just making the time to really be present with patients. Some of that's changing. There's some good things with AI and leveraging technology for that. But the true healing comes when providers and patients can be together and be open about what's going on. Just like, my dad and other generations did in the past, we can still do that in the present, is being present with people and instilling hope in the future and a sense of compassion and empathy that are really important to healing.
Yeah, and I know you and Iris Telehealth, you're making a major impact in this. But I think in our first conversation, you said the real challenge is like keeping patients well between their appointments. And, why does our system still wait for crisis instead of like preventing it?
Yeah, I wonder that as well, because, I learned something, a big lesson I learned practicing in New Zealand. And being called to the emergency room sometimes for consults, I would often remark at how quiet the emergency rooms were. And in working with some of my family or some of my emergency medicine friends that were in New Zealand, they said they often had to go back to the U.S. for a few months every couple of years to see enough patients just to keep their certifications, because you didn't get the volume of people coming into the emergency room. So I was fascinated about that. I was like, wow, that's just amazing. I know it's not a big country, 4 million people, but they're humans like everybody else. Why did they not come in? And they said that the system is just not designed that way. You have a GP, a family doc, internist, and that's who you go to. And you really don't go to an emergency room unless it's a true emergency that requires something right there. The great line in that movie, Doc Hollywood, that you may have seen, Michael J. Fox, is there's that old time doctor there, and he's like, don't call me unless you're stabbed, shot, separated from an appendage, or otherwise about ready to bleed to death. I just remember that. That's what emergency rooms are for, severe illness. When you don't have access to care in your communities for more routine things, people just go to the emergency room because you have to get care. In New Zealand, you actually get charged a fee when most of the healthcare was free. If a person went to the emergency room, we might get charged $50. And $50 in New Zealand is like $500 in the US. It's a lot of money. So people didn't do it because there was a cost to it. They waited if they could. Our system has created access to care through an emergency room. You come in for anything, can't be turned away, give you a medical exam. And that's great. I support that. That's a great thing. And so I don't blame patients for utilizing that. That is part of it. But it's a system we created for them. And even with the community mental health centers that are just so jammed with patients now, some around here in New Hampshire where I am, over a year wait list to get into a community mental health center. They're being asked to do things that is not, that was not the way community mental health was designed to do, the volumes and meet all the needs of everybody in that town or that community. So we need to rethink how healthcare is delivered. And as you were talking about it, keeping people well before they have emergencies, before they have crises. There's different levels of care. There's emergent, go to the emergency room. I'm gonna kill myself. I'm gonna kill somebody else. I'm severely psychotic. I'm not eating. I'm not taking care. I'm decompensating. Those are true emergencies. Then you have people who are in crisis. And with the advent and growth of crisis centers now, mobile crisis, driving around, things like that, crisis centers that are not emergency rooms but are 24/7. There's not many of them. It's a growing concept. The funding, the reimbursement modeling to staff them is very challenging, but that's a great model. But then looking at virtual care, virtual behavioral health, virtual physical health. Your insurance now, most of them, if you have just a bad cold or sinus congestion or something, you can go online and have a televisit fairly quickly with a doc. Like within 30 minutes, I could be in front of a doc right now. That's really cool. For behavioral health too, that's really cool. Having people on call to do that work, it costs a lot of money. So the traditional models for how we pay docs, nurse practitioners to do the work has to change so that people know that they can get help before things get to the level of crisis or emergency. They're not feeling well. They're not sure what to do. You try to get into your practice nearby. Oh, it's 6 months. Oh, it's 2 months. Well, what else are they supposed to do? But if you can create like a virtual pathway to see somebody, to get some basic support and triage, to know that they're not alone in their journey, and then try to see them within a few days or even that day, that's the capability of telehealth. And not that they have to drive to your town or you have to be in that brick and mortar building. You could do it anywhere as long as you're licensed in the state where the patient is. We have providers licensed in all the states around the country. You can go to them. You can see them in your home. So the telehealth legislation that had expired during the recent government shutdowns, and it got extended now again till the end of 2027. That is a huge win for patients. You can see them in their homes virtually. That is just such a cool thing, a cool concept. And I think we're only scratching the surface of what that means in terms of how patients get care. It's still challenging sometimes to access a provider and the tools that you use, the technology, but it's getting better so that people can reach out and get care before things become a crisis or an emergency.
So let's talk just briefly about your sort of approach to the business model here, because, a lot of people are familiar with telehealth that's aimed direct to consumer. I mean, we've all seen the BetterHelps and the things like that, and it understand that is telehealth. But your approach is more of a business to business model where you're wanting to go to the health systems, the primary care docs, the hospital systems. So what was your thinking in making that choice?
No, it's a fun question to speak to because it is about evolving care. I keep this statue behind me, on this side, fetching the doctor was my grandfather's and my grandfather's microscope, just to remind me about the evolution of how we do science and do healthcare. As going and getting a horse and bringing the doctor to the patient's home. It's still the same concept. It's just different technology. We started off back in 2013 just meeting unmet needs in community and mental health centers. They just didn't have enough providers. So we supplemented that, sort of help them have more hours to see patients in the community, to get people in, so they didn't have to then go to the emergency room and let things build up.
That was kind of like a phone a friend model, right? They're like, we need help, so it's like phone a friend. We've got you on speed dial, right?
Exactly. So, and that was kind of like a staffing model to where we had Iris providers and contracted with initially with community mental health centers and then with primary care, doing primary care integration. They might need somebody 20 hours a week or 15 hours, 16 hours a week or full time. That expanded to working with FQHCs and rural health clinics. But it was somewhat staffing and that worked well. It really grew, became very, very busy well before COVID. But what we realized was that it wasn't just these individual clinics and FQHCs, it was large health systems as well that wanted to do behavioral health better, but just didn't know how to go about it. And to be honest, this is what I learned when I was interim chair at Virginia Tech for a couple of years. Behavioral health doesn't generate much income. I mean, we were maybe 1% of the hospital revenue. It comes in through interventional cardiology and surgery and other things where you can, there's a lot more avenues for billing. With psychiatry, for most of the work, there's like one code that I can charge. There's not a lot of other things I can do. I can't freeze warts. I can't, remove skin tags. I can't do Botox or things through telehealth or whatever. It's talking to patients, prescribing, diagnosing mental health. So there's some challenges there. But as we work with large health systems, they began to share with us, not just that they didn't have enough people, but they didn't have the right model for how to serve their communities. And that was a big change. And that's been within the last, I would say, like 5 to 8 years, where organizations embraced wanting to have people with behavioral health in their system. They want to capture those patients because those are also folks that have COPD and asthma and diabetes and heart disease and other things that are very costly. And as you look at data, the really good data like Milam data and others, people with chronic physical health issues that also have behavioral health or addictions issues cost a lot more. So if you can treat the behavioral health issues and keep people well emotionally from a mental health standpoint, their physical health also gets better. And the cost of care, the amount of times they have to go to the emergency room or be hospitalized, the cost of care goes down. So organizations begin to look for us to help them recreate the model, not just to serve the patients. And that's been Iris's journey for really the last 5 years, is working with large healthcare systems around the country. I mean, we still do all the community clinic work. It's the biggest part of what we do. Teach people with Medicaid, Medicare, no insurance. We work with organizations to serve those folks. That's the heart of what Iris is. But we also work with organizations to be creative in how they build out behavioral health systems. So we've helped some large systems build their entire ambulatory behavioral health departments where there was none. Now they might have 20, 30 Iris providers doing their ambulatory care, seeing their patients in their system, connecting to primary care. So they're held in that system, that what we, PCMH, a patient-centered medical home, when you hold people and can care for them and keep them well in one place instead of it being so fractional and siloed. It seems to be what works better for patients because they know where to go. Even today, you got to go somewhere to get your lab, somewhere else to get your imaging. My wife had to go get her mammogram somewhere else in our new town here, somewhere else to get your endocrinology. When you can pull that stuff together or connect it through telehealth from different sites, but the hub is something that the patient and that care system can access and their insurance can access, that optimizes care. It optimizes the patient journey. I think it's not that patients don't want care. They do. They just often don't know where to go. And when you're confused and you're not feeling well, you end up going to the emergency room. So leveraging telehealth and working with health systems to find other avenues to recreate different models for access has been a big part of what Iris does around the country. And it's really meaningful.
Yeah, Tom, staying on the subject of evolution, you walked us through just what you've seen since 2010 of how telehealth has transformed and transitioned. And you mentioned earlier just about AI, and it would be interesting to hear from you just where you believe like AI is delivering real value in behavioral health and with Iris. What are you doing to incorporate that in?
No, I love that question because it's an important time for that. I think we're all looking at AI in healthcare and how it can be a win for the patients, but also for the health systems. And it's got to move beyond just like apps. Here's an app for your mood. Here's an app for tracking your sleep. It's a lot of people, my wife included, loves tracking her steps and all. I just don't need to know how many steps I took or not. I know if I took a lot.
Listen, I'm guilty. I'm in the Garmin universe, and it's like I actually do look at those metrics and probably more than I should. So I might side with your wife on that one.
My thing is I forget to charge the things. I forget to plug stuff in. I've been looking at those rings you wear that track blood pressure and things like that now. Blood pressure meds and all. It's genetic, runs in the family, but. I try to stay healthy as well, watch weight stuff. It's interesting, and to each their own in terms of how much they want to be involved in that. But to me, one of the things that's key in medicine, in both with communication with patients, but also communication among health systems and with other providers, is that it has to be meaningful. So, not just that you did go see a psychiatrist. I referred you and you went and saw somebody so I could check off the box at You mentioned feeling depressed, and I've referred you, so my work is done. But it's meaningful that you refer somebody, and I send you something back electronically that tells you what I did. And it's not just me typing at a keyboard, even though, I still do a lot of that or use dictation software. Increasingly, ambient listening, which is being a game changer for healthcare providers in the right environments, it can summarize and take your time with the patient. So instead of, imagine if we're talking and I'm sitting here clicking, or worse, I'm over here clicking away, looking over at you every once in a while, like my internist does. Bless his heart. I don't mind. I get it. I don't blame him for doing that. You got to enter that data, have it done by the time you leave that room. But if you're trying to see a psychiatrist and they're looking over this way, asking you questions and all, it isn't going to fly well. And I took cooking in high school rather than keyboarding or typing back then. So I'm not a great typist. I wish I had done something like that when I was younger, learn how to do keyboard stuff. But I, learned to use Dragon Dictate and stuff like that, and different dictation systems. These days, having quick access where patients go see somebody, the visit is summarized, it's shared with their other providers, and not shared like long notes. Like back when I was teaching a lot of med students, I'd make them print out their progress note, because I said, guys, you're just putting everything in here. Residents too. It's like, I want to show you. And I would tape them starting at the top. They would run down the wall and onto the floor. And it's like, that is how much information you want one of your colleagues to look at. It's just worthless. It's not meaningful. So you can try shortening and doing things and using templates. AI has leveraged the ability to capture the important things, to organize notes in ways that are meaningful. It also, so that's meaningful in terms of sharing information about providers, or me having a nice summary of a patient before I see them, because that's another thing. You're seeing a new patient. You got to look at their chart. You got to look at their record. You're radiologist. You got to look at their scans. You're a surgeon. You got to look at their imaging studies, and there's a lot of stuff you have to do before you see patients. So getting that efficiently in ways that are meaningful and accessible, AI does a great job of that. I think in here, sort of, my punchline here for it is, I think that we will all have a central core medical profile, whatever it is, that has all of our data in it from childhood on, if it's stuff that's accessible. Like, I grew up with paper charts until I was, until I got back from New Zealand. Like, paper charts, I carried 40 boxes of books around of charts with me around for so many years, because you had to. But all that's gone now. You can move around and have access to your files, and not files that I have to scroll through and look for, but AI can leverage looking at people's pharmacy profiles, looking to their ED utilization, looking at their diagnoses, looking at times to care, breaks in care, looking at their family history, looking at genetics. It can synthesize these in ways that help you as a person, as a patient, understand your health better. You own the data. It's your data. So orienting patients to that. Why do I need to know my pharmacy stuff for the last many years or whatever? Because there's patterns in it that say a lot about you, about what works and what hadn't. What did you have side effects with? What cost a lot? Why did you stop certain meds when you said you were doing well? There's a lot of patterns in there. So if we can create these databases, pull that data together in a safe way, and then from patients and providers of healthcare systems alike, access it in ways that are meaningful so that you understand your health. I know that I have high blood pressure, and occasionally, I was sort of pre-diabetic many years ago, some, gout, some other stuff. I don't know how all that stuff relates to one another. But if I had a healthcare database that was designed to help me see how those things were related, and how different medicines that I might be taking work with each other, not just against each other, that's an informed patient. That's an informed healthcare system. That to me is the gold standard of what AI can do. Now, Iris has Iris Insights. It's sort of a database of all these biomarkers of patients. And I'm using that term biomarkers, not like traditionally in medicine, but biomarkers in terms of your pharmacy, your visits to different providers, different specialties, pulls all that together to help you understand yourself, to help the provider you're seeing understand your journey, and to help make decisions about what's best for you. Tie that into nutritional support and diet. Tie that into ways to cut out smoking or alcohol or substance use. Tie that way into healthy parenting styles. So we work a lot with women's health, perinatal stuff, perinatal depression and things. How do you support people? Well, we can support you with that too. We can get providers that can support you being an early parent or something. The AI can leverage where the meaningful areas that you think you have and where your providers are pointing out where you can really get services that impact your life, whether they're physical or behavioral health.
Well, a lot of people who listen to this podcast, they either own programs or they're thinking about starting programs. And one thing that all of them, I think, understand is the complex comorbidities that the patient that they see have, right? And so it sounds to me like, what you're building is potentially this holistic viewpoint that people could tap into to see that Jane Doe or this is what's going on physically. This is what's going on mentally. This is what's going on in terms of, their pharmacogenetics, all of these things that frankly, simple intakes just don't do anymore. And that's what I think a lot of our programs are dealing with in terms of intake forms and things like that. They're not getting the whole picture. So how could they tap into that?
Yeah. No, I think that's a great thing. I look at the evolution of healthcare, the evolution of my own work. When I was in private practice, I knew I didn't have time to fish around to learn a lot about the backgrounds of my patients. So they would call, they'd say, I'd like an appointment. You say, all right, we'll schedule you one soon, but I need you to fill out this paperwork first. And it was stuff I designed with all these questions and little paragraphs that you kind of had to hand write in generally, because that was the way you did it back then. And then they would mail those in. I would review them, and then we'd set up the appointment for the patient. It was like I didn't feel comfortable just having someone walk in cold. I was like, if we're going to use our time effectively, then I need to know something about you ahead of time. And I still had to read through all those papers and things like that and synthesize them. And some stuff was great. And sometimes patients just wrote whatever or say, I don't know. But if that data could be summaries based on actual events, when they've gone to the ER for what are their primary diagnosis codes? So it's looking at billing data. What did insurance get billed for? Were they in the hospital? For what? For how long? What's their pattern of pharmacy usage in terms of, how much they relied on SSRIs or SNRIs or stimulant medications for ADHD? What's the usage pattern over time as far back as the records can show? What are events that have happened in their lives? Births, accidents, things like that. All these inform us. Their family relationships. They married or have a partner, or they binary or transgender. What are the things that are part of their unique makeup? How they celebrate their lives, but also what are the areas in their lives that are not going well that cause depression or anxiety or stress or sleep problems? Because those problems feed your physical health. When I'm stressed, like we all are, your blood pressure goes up. You release more cortisol. Your sugar is more poorly regulated. You're releasing more inflammatory cytokines, so your joints are going to hurt more. You're going to have a headache more. You're not going to feel as active. It's all related. So the more that we can help the patient understand the interrelatedness through summaries of what their life has been and what their kind of their medical profile or patterns have been, and share those in a meaningful way with the providers that are taking care of them, that optimizes care. So I think healthcare systems working with patients and their own system to build out that is the biggest win for AI. It's not just I can dictate see a patient and talk to them like we're talking, and at the end I have a nice note that I just need to review and co-sign. That's a nice thing. But it synthesizes their picture. And the nice thing you'll see in many of these appointments where you're using ambient listening, the patients are very aware of the report. You could show it to them, the new laws that require patients to have access to their medical records right away. They're going to see what you see. So everything's transparent, which is a good thing. Patients know what's being written about them. They know what's being recorded. So if you invite them into that journey from the very beginning about shaping their medical, their behavioral health story, the better that's going to be translated throughout their lives to other people who are invited into their care. So that's that concept of, it's not just the patient coming to us. You come to my brick and mortar visit, you take what meds I give you, I'm the doc, you're the patient, you do what I say. That sort of patriarchal way of approaching medicine is gone. AI is leveraging the playing field. When the healthcare app that came out that has it has healthcare data and healthcare information, people were writing me like, "Oh, they're not going to need doctors anymore. This is the end of the beginning of the end." And I was like, "No, this is exciting. You're going to have really informed patients. They might come to you and want, hey, I want this drug. I'd rather they have read about it than they saw it on a commercial during the Super Bowl or something and say, hey, I think I have that. I want that drug." But if they can read about it ahead of time and come and be informed, then that's a good thing. It's not that I'm trying to convince them not to take that medicine. It's like, well, tell me about why you think you might need that medicine. Let's talk about it. They're part of the journey. That, to me, is key to the future of healthcare. Patients are part of the journey, not just the providers giving them care.
I couldn't agree more. I'm just sitting here listening to this and more hopeful and optimistic about what that conversation with the provider is going to look like, unlike what it is today, where it's almost like going to an auto body shop or something where it's just like, well, I need new tires and I need an alignment and, and then I'm out of here in an hour, that kind of thing, as opposed to somebody, it's like, well, let's take a look at the bigger picture and what's really going on. I mean, to me, that's where we really start seeing it feels more human. It feels more human and it feels more hopeful to me.
I love cars, and I've had everything from Model Ts to Porsches and things. I just love cars and the evolution of cars. And you speak to it. Medicine is not a Jiffy Lube. I'm not against Jiffy Lube. It's a great, company. Right. These fast oil changes. That was an evolution. You used to go to your mechanic, your mechanic in your town. Then these organizations, let's offer this service of, we'll come in and check all your fluids and change your oil. That's the evolution of how you take care of things. Medicine can't be Jiffy Med or something. That's what doesn't work. It can't be faster and faster. And insurance might want that. Some healthcare organizations might want that because you bring in revenue for every encounter. Evolving out of the encounter-based, just how many clicks, how many people you can get in front of you, to quality and meaning-based, building relationships, educating patients, helping them stay well instead of just, what's the problem? Here's your quick fix. Did it fast, 10-minute visit, go on. If we can build ways that help achieve those goals of efficient care, but also meaningful care that patients feel like they were heard and they buy into the care and buy into that journey, that's what's going to keep them well long-term. High blood pressure is not a problem initially. It can be. Down the road, 10, 20 years with it, you're going to end up being a very expensive patient. You throw in some diabetes, some asthma, some smoking for 20 years, whatever, you're going to be a very expensive patient. If we can try to help patients understand those patterns and the connectedness between them earlier on, and that's the work of healthcare systems. That's on us, not just on the patient. It's not blame the patient, blame us. We need to work and find better ways as healthcare systems in this country to help people understand their care on a longitudinal basis, to help them track it in meaningful ways, things that AI can leverage. That's the fun part of Iris right now, too, is helping work with organizations to do that. What are their goals? What are their patients' goals? And being part of that journey. It's a lot of fun, and I'm really hopeful and excited about it as well.
Yeah, Tom, this episode has been very insightful and very encouraging, and we appreciate all you're doing for the industry. What, as we start to wrap up, though, is there anything that maybe we didn't ask or that you'd want to share with the audience?
No, I think you've covered a lot of areas, and I'm a talker. I'm a preacher. I like to talk, but I like to talk because I'm a clinician educator. And some even in corporate world, some you got to talk less. It's like, no, you need to listen more. I'm not saying that I have a whole lot more to say, but learning to listen is an art in psychiatry, but it's also art in all relationships. If you can't learn to listen and shut off your own brain and listen to someone else while they're talking, be it your spouse or partner or one of your kids or your neighbor or somebody, if you can't do that, or we can't do that in healthcare, that's a problem. When you work too fast, you don't listen well. You're just, what's next? What's next? That's not a healthy environment. I wonder what my kids' experience is going to be being physicians. My daughter working in the ED, boy, she's just tired all the time. All the time. We keep saying, when are you all going to get married? You've been engaged for like 3 years. Just don't have the time. Just too tired. Medicine can affect your life. Most of us are in it. We're all in. We love it. I love it. I would do it all again. Wouldn't change anything. I think the tools now with AI, data transparency, enable us as providers to synthesize things better so that we understand patients that are sitting in front of us, but also in partnering with them, they understand themselves better. They understand what depression is before they come to my office. They understand what ADHD or anxiety or panic or these other things are before they come to my office. That's an informed patient. That's a good thing. So them having access to that data. I mean, I still have AOL for my primary personal account. I still have AOL. I'm like one of 10 people left. But I had it when it was IO,
No, I'm actually surprised you wanted to go on record with that.
Yeah, I was going to say.
I'm just saying that's a good thing. You stick with it. But back then you had to dial up, and then it was DSL, or you had to choose the phone numbers. They were busy, and you had to choose different ones. It's evolved. Healthcare is evolving. Communication is evolving. That's a good thing. When social media came in and parents were like, oh, my kids are doing this stuff. Yeah, I saw that. But what I also saw was the kids with severe autism or social anxiety would come in and talk about their friends. It's like, what? You had friends? You interacted? Well, yeah, they're virtual. I've never met them. And now, like, working through that to say, well, that doesn't mean they're not real. They're real people. You're connecting with real people through the internet, through social media, or whatever. That's a good thing. That's a win for a lot of these folks. That doesn't mean there's not dangers to it as well. Technology can be used to help patients get well, and in medicine, it can help optimize care. Yes, there's billing, there's organizations owning the behavioral health journey, and how do you find value in that, the value-based care kinds of things. There's a lot of value in caring for people with behavioral health and the downstream effects that can have on their physical and mental health. So it's an exciting time. I think I just want healthcare systems to be open to it, to continue to embrace the importance of their behavioral health play in their organizations, and to know there are organizations like Iris Telehealth and others that are there to support them. Whether people partner with us in the end, it doesn't matter to me. It's that they engage with us to ask the questions, and I always honor that.
Yeah.
Well, Tom, I'll say, there are a lot of things that we could have gotten into today, which we probably will want to come back to you in the future. You mentioned value-based. That's a big topic in our industry, and we didn't really get to touch that today. So maybe we'll come back on a second episode. And then the last thing that I want to say is that I just feel like a kindred spirit here. Is like, I'm also the grandson of a country doctor. And it's like, I know that whole story, and it just feels like there's a lot of really great intersections here. So it's just, it's really been brilliant having you on the show today.
Thank you. It's been meaningful for me as well. And thank you for providing this. You all have a great podcast. I think it's a wonderful thing that you're offering. And I think it will certainly bear fruit across the country and helping with the healing process and helping organizations in their approach to providing great care to their patients.
Yeah, Tom, I know a lot of people that listen to this podcast are probably going to want to reach out to you. What is the easiest way to connect with you if somebody has a question?
Yeah. Tom.
That would be at AOL.com, right? I'm just kidding.
Yeah, exactly.
And we can drop your contact information into the show notes.
Yeah, I didn't mean to cut you off, Tom. Go right ahead.
No, someone once said, you've got a legacy AOL account. That you could sell that. I was like, oh, okay. But I will just say, Milam at iristelehealth.com. That's my email, or, our company has contact information for organizations. We're not a direct-to-consumer kind of thing. We work with organizations in communities and across the country that are supporting the states and the communities that they're in. That's the kind of work that we do. So there are other companies that do direct-to-consumer, but I'm certainly glad to have organizations reach out if they're interested in talking more. We have a great creative team of people at Iris, which is why I've stayed there. If we can't put our heads together and figure this out with patients and healthcare systems, I don't know anybody better suited to do that. So it's been a real pleasure to be with the leaders and the teams at Iris.
Awesome, Tom. Well, thank you. Thanks again. That's a wrap for today's episode. On behalf of Jeff and I and the entire MasterMined team, thanks for tuning in today. If today's conversation with Tom sparked any questions, please drop them in the comments section, and we'll be sure to get them over to Tom and get them answered and back over to you. So thanks for tuning in. We'll see you next week on MasterMined.
That wraps up this episode of MasterMined. Thank you so much for joining us. And remember, MasterMined is not just a podcast, it's a community. So don't forget to comment, subscribe, and review us. Your feedback helps us continue to bring you content that's relevant and relatable. Thanks again to our sponsor, Snapshot, a digital media marketing agency. And thank you for joining us on MasterMined, your behavioral health playbook.